Hello all. Today we'll be discussing the other topic on bone tumor, that is your osteochondroma. So basically, what is osteochondroma? Osteochondroma is nothing but a benign bone tumor. It is a benign bone tumor. This is the first thing you should remember. So it arises from the cartilage, which forms an exophytic bone growth, which is capped with cartilage. So this is the definition for osteochondroma. So what is the definition? It is nothing but a benign bone tumor. This is the first thing you should remember, and it is always benign, it is not malignant. So it arises from the cartilage. So this is the second point you should remember. So it is an exophytic bone growth. As you can see here, it is an exophytic bone growth. This part, it is an exophytic bone growth and it is capped with the cartilage. This region is the cartilage. So this is the definition of osteochondroma. So this is also known as exostosis. So now let us understand what is exostosis. Exostosis is nothing but a benign bony outgrowth which arises from the surface of the bone. As you already seen, it is very simple to understand what is exostosis. So then it is the most common benign tumor. This is what you should remember. It is the most common benign tumor. And next, it is not a true neoplasm. It is not a true neoplasm. Why do they say that? Because osteochondroma is a developmental bony lesion. So there is no malignant potential or no uncontrolled growth. So that is why they call it as not a true neoplasm. So what is the most common site which is affected in osteochondroma? It is the physis. So it initially starts from the physis, but when it grows, it affects the metaphysis. So the growth is arising from the metaphysis, but it initially starts from the physis. As you can see in this image, it starts from the physis and then goes towards the metaphysis, and here you can see the exophytic bone growth which is in the metaphysis. So initially you should say that it is arising from the metaphysis which then goes to the metaphysis. So this is what you should remember. So they also say that osteochondroma is a growth plate aberration. It is a growth plate aberration. So what do you mean by that? It is nothing but there is a disruption in the normal function of the physis which leads to an abnormal bone growth. So osteochondroma is nothing but an aberrant plate aberration, which is growth of the aberrant cartilage which proliferates from the tumor growth plate. The most common age affected is around the second decade. So it is most common in males than in females. The most common site affected here is the distal femur, which is greater than the proximal tibia and which is greater than the proximal humerus. So the most common site is your distal femur. It can also affect the flat bones, but it is very rare. So it rarely affects the flat bones, that is your pelvis and your scapula. So on presentation, this osteochondroma can either be a solitary lesion or it can be a multiple lesion. So there can be one bony outgrowth or there can be multiple bony outgrowth. So multiple bony outgrowth is also known as diaphyseal achalasia, which in other terms is known as your hereditary multiple enchondromatosis. So you should remember this because this has malignant potential. So it is very important to know about this hereditary multiple enchondromatosis. So coming to the diagram, you should remember this diagram when you are thinking about osteochondroma. So you can see the bone here, and here the cortex as well as the medulla. Here you can see the cortex as well as the medulla is continuous with the lesion. So this is a very important point you should remember. So this also has a cartilage cap. This cartilage cap is also very important, and I will let you know the importance in the coming slides. So coming to the types, there are two types of osteochondroma. One is your sessile type, which is nothing but your broad based swelling. Can you see? It is broad based. This is broad based and it is less prominent. On the other hand, you can see this exophytic growth, which is outpoaching from the bone. Here you can see this region is known as the stalk, and this is the swelling. So this is known as your pedunculated osteochondroma. Here there is a stalk, but here there is no stalk. So this grows away from the joint. So this you should remember. So coming to the clinical features, it is a painless bony swelling. So you should remember this. It is a painless bony swelling. So the other clinical features can be, because of this bony approach, there can be pressure symptoms over the nerves. There can be pressure symptoms over the nerves, over the blood vessels, leading to complication. So these are known as pressure symptoms. There can also be development of pseudoaneurysms, and as we already discussed, this stalk can fracture in some patients. This stalk can get fractured in some patients, leading to pain. So these are the clinical features of your osteochondroma. So coming to the radiological part, where you can see there is a simple bony outgrowth. There is a simple bony exophytic lesion. So it can be either sessile or pedunculated. So this, which is growing away from the joint and it is in the metaphysis, is your diagnostic characteristic of osteochondroma. Here the cartilage cap is not visible in your X-ray. So how to identify this cartilage cap? So to identify this cartilage cap, you need to get a MRI done. So this is an MRI image which shows the cartilage cap. Here in MRI, it is very imperative to measure the size of the cartilage cap. So why the size is very important? Normally the cartilage cap is around 1 to 2 centimeters or less than 2 centimeters in adults, and in children it is almost 3 centimeters. So whenever you see the cartilage cap is more than 2 centimeters in adults and more than 3 centimeters in children, it is suggestive of malignancy or conversion into chondrosarcoma. So here it is very imperative to take an MRI for all the patients just to identify the cartilage cap thickness and know whether the patient is undergoing any malignant transformation or not. So coming to the treatment part. So coming to the treatment, if the patient is asymptomatic, because most patients are likely to be asymptomatic, they can be treated only by observation. There is no surgical treatment is necessary for these patients. So, and you need to routinely follow up these patients, and serial follow-up is needed to look for any growth or any malignant changes. So if the patient is symptomatic, so when do we say the patient is symptomatic? When the patient is having any pressure symptoms like pain, because it is a painless swelling, any vascular or nerve compression, any mechanical symptoms like blockage, or if there is feature suggestive of malignancy, then the patient can undergo surgery. Here the surgery that is done for osteochondroma is extraperiosteal excision. Extraperiosteal excision. Another important point here we should know is what is the recurrence. The recurrence is very rare and it is usually not a recurrent tumor unless it is completely excised. So what are the complications? So the most important complication here is the malignant transformation. So whenever in cases of solitary osteochondroma, the chance for malignancy is only 1%. But whereas in multiple osteochondromas, that is in hereditary multiple enchondromatosis or exostosis, the malignancy conversion rate is 5 to 10%. So when do we suspect malignant transformation? When there is a sudden increase in size or the patient is having pain in adulthood, because this is a tumor most commonly seen in children and this is most likely to be benign, and whenever there is pain and the patient is complaining of pain, you can suspect a malignant transformation. The other complications are there could be a fracture at the stalk site which can lead to pain. There can be pseudoaneurysm, nerve compression, and there can be growth disturbances. Since the physis is also involved, there can be growth disturbances. So this sums up your osteochondroma features. So coming to this slide, you can save this. This gives you a complete thing of what you should remember whenever you're reading about osteochondroma. So the first most important thing is it is the most common benign tumor. So this is the first thing. It is a very benign tumor. That is what you should remember. So it originates from the metaphysis. The most common site is your distal femur followed by your proximal tibia. So it can be either solitary or multiple. So in multiple, it is also known as diaphyseal aplasia or hereditary multiple exostosis. It can be either two types. One is your sessile or your pedunculated type. So sessile is broad based, which is arising from the surface of the bone, and pedunculated, where you can see a stalk which is outpoaching from the bone. So here, the most important feature or pathognomonic feature is the cortex and the medulla are continuous with the bone. So coming to the clinical features, it is a painless bony swelling. So on X-rays, you will not be able to see the cartilage cap. So an MRI is done to assess the size of the cartilage. If the cartilage cap is more than 2 cm in adults, it suggests of malignancy. So a few points on hereditary multiple exostosis. It is a malignant conversion and the chances of malignant conversion is approximately 5 to 10%. The most common gene which is responsible for this mutation is EXT1 gene and EXT2 gene. So coming to the treatment part. So if the patient is asymptomatic, there is no reason to operate the patient. So you just observe the patient and keep him on serial follow-up. If the patient is symptomatic, just go with extraperiosteal resection. So this gives a clear picture of the osteochondroma, what you need to remember. So it is also another point which I missed is the age group most is 2nd to 3rd decade, and it is most common in males than in females. So I have also concised this in a form of a reel in shorts where you can go through in my Instagram and as well as in your YouTube shorts video. So if you have any doubts, please do let me know in the comments. I can clear your doubts. So I'm also planning for a practice MCQ based session, and if you really need any practice MCQ on how to attend these questions, please do let me know. I'll make a separate video on that. Thank you all.